Thank you so very much. I can see my presentation. So we are today just touching upon in the coming 20 minutes about common eye problems in family practice. So may I have my next slide, please? Yeah, see, so this is what, Dr. Mohammed and other doctors, they have given me list, We already, everybody have given me feedback of red eyes, you do conjunctivitis, you see vitamin A deficiency, dimness of vision of various causes, that is refractive errors, cataract, glaucoma. These are the main causes, especially in senile age groups and young age groups. Somebody even replied me that they do see a case of corneal ulcer. You see foreign body in eye, or maybe headache, which is also very important reason for patient to see a general practitioner, because you really want to know about whether this headache is just a stress headache or ophthalmic headache or ENT headache or migraine or whatever. So you must be getting, I'm sure you must be getting cases of chemical burns, maybe alkali or acid burns, especially, you have nearby factories and things like that. And somebody told me even about stye and chalazion. Next. So, I have made my presentation very interactive. For example, if you see, if somebody can point out case one, right? So, that is a subconjunctival hemorrhage, People either post-op or otherwise, maybe sometimes vitamin C deficiency, they would come to you with a large localized hemorrhage. You can't do anything for that, because it is something like how you have a blunt trauma and you have a red patch or a black patch on skin. So these patients are just to be reassured, and you just let them go. My second slide shows you a purulent conjunctivitis. You can very well see, yeah, thank you so very much for pointing that. The lot of discharge, which is yellowish green, and lot of lead edema. So your spot diagnosis is conjunctivitis. So how do you treat that? Most of the time, what I have seen is not, of course, you, but people do as an anti-inflammatory, they do use a lot of steroid drops. I think that's one thing only an ophthalmologist can decide whether or not you should give a topical steroid drops or not. So, like, these are the patients. Please keep in mind that you all are treating them correctly, but this particular patient has to be given eye drops, especially broad spectrum antibiotic eye drops like ciprofloxacin or moxifloxacin or Vigamox, which is a very favorite name for you. You have to give hourly. Even I don't mind if you start giving these drops half an hourly, because that reduces the load of organism. That's what it is going to do. So, till you get less discharge and less symptoms, you must continue this. Overnight, what you can do is prescribe an ointment. Ointment has to be, before sleep, because you want it to be retained in your eyes and act for a longer time, right? So the next thing which I'm showing is somebody pointed out red eye, but a pterygium. Can you see that third slide where, there is a hipped up tissue on the cornea, and there is a wing like elongated thing in the conjunctiva. Generally, it is on the nasal side. So this pterygium, unless and until it is a flashy red pterygium which is causing dimness of vision, pterygium induces astigmatism. Okay, because pterygium pulls the cornea horizontally and it changes the cylindrical power of cornea. So the indication of that is just dimness of vision, and patient is getting temporary glasses having cylinders. Not only that, of course, there is a cosmetic purpose where your patient doesn't want to be, looked like this with a red patch in his or her eye. And also sometimes there is a restriction of movements because of pterygium. So flashy pterygia sometimes causes even diplopia. So these are the indications. But one should keep in mind that, pterygium surgery, at least in 2 to 5% cases, gives a recurrence. So, it's always good that an ophthalmologist decide, when to operate. The fourth case I want everybody to see because it has showing a hazy cornea. See, other four slides, you have a very clear cornea, but this particular fourth case have a hazy cornea. So this is not the case to be dealt by a general practitioner. You can reassure your subconj hemorrhage patient. You can treat your acute mucopurulent conjunctivitis. You can even advise for a pterygium. But when you see hazy cornea, it can be mainly because of two reasons. It is either a glaucoma, or your patient is having a keratitis or a iridocyclitis and a secondary glaucoma. So these are the various causes. Fifth slide, I think I want you to see, because that is what I'm showing, a viral conjunctivitis. Here there is a red eye, and either this can be a viral conjunctivitis, or you look through a slit lamp, it can even turn out to be an iridocyclitis. Viral conjunctivitis generally, takes its own time, and like it gets treated on its own, but generally the topical antiviral drugs doesn't help. So these are the few cases where I wanted you to understand about how, what are the red eye things and how do you treat that. Next, so whatever, see, this is what I am wanting to show you, that first is a bacterial conjunctivitis, the second slide is a viral conjunctivitis. It doesn't have much symptoms but a lot of red eye, like you have many subconjunctival hemorrhages because of the viral conjunctivitis. The third thing which I'm just putting a crossover is when we evert the eyelid, you see lot many follicles. So you have two varieties of conjunctivitis. One is bacterial, second is viral, and third is allergic conjunctivitis. So unless and until you are sure to have the patient to have an allergic conjunctivitis, you should not treat, because this requires either antihistaminics or steroids. Next. So, you all are getting many patients of dimness of vision, either for near or distance. So let's say it is a child, this is mainly because of the refractive error, or maybe, it is a dense kind of dimness of vision for near and distance both. It may be something related to congenital cataract also. So I don't know how far it is true, but I was just once upon a time talking to a pediatrician friend and even a general practitioner, whether or not a good general practitioner can have a Snellen's box in his or her clinic. I've been seeing many general practitioners practicing wonderfully, and they do a lot. So this is a one simple thing. You can actually see whether the child has a refractive error or something else by just taking a pinhole vision. If the vision is very poor, and if you put a hole in front of a patient's eye and the vision improves, that definitely means that he or she has a refractive error. If it doesn't improve, then it can be some of the organic causes. If we talk about adults, for near vision, we all know that it can be either a presbyopia, or if it is a senile age group, it can be a cataract. And if it is associated with pain and redness, it can be glaucoma. So, if you look through a patient's eye carefully, in a pupil, instead of the black reflex, you may see a dark gray or a white reflex if your patient has cataract. So what you do is, ask him to close his eye with a palm, because a palm will not allow any light rays to fall on that eye. So if that patient is having a very dim vision, which is not even improved by glasses, and you can see a gray reflex, that can definitely a cataract. Why I want you to know this, because it is the patients have a lot of confidence in general practitioners, and if they are clinically very efficient and you label this as, sir, maybe you have a cataract, or I feel you have a glaucoma, they have a lot of faith in you, and they feel that my family doctor knows about everything, whether or not he can perform a surgery, but he can really guide me very well. So senile I talk about is, it's not only cataract, it can be some retinal degenerations, or corneal degenerations or maculopathies, or it can be diabetic maculopathy or retinopathy. So depending of which age group patients are coming to you for near or distance, roughly you can even put the diagnosis. Next, please. So somebody was telling me and replying that they do see cases of corneal ulcer. Now look at that first two slides. It's a twin slide. The first slide is kind of stained with a fluorescent. It is staining positive, and the lower side is also a corneal ulcer. Now, why do you call this a corneal ulcer? Because it is also having lead edema and lot of congestion, right? So the patient's vision has been lost. You can see a white opacity in cornea, which is associated with redness, lot of lead edema, maybe watering. So these are the patients. I think I wish that general practitioner can simply start with a broad spectrum antibiotic drops, which covers both gram positive and negative. You can try moxifloxacillin for such patients as a repeated line of treatment, and one single drop of atropine, which does wonders till he reaches an ophthalmologist. And I'm sure your ophthalmologist is going to praise you once you use one drop of atropine as a cycloplegia. This cycloplegia reduces a lot of pain, and patient becomes, symptom free till he goes to a doctor. And then it's our job to do gram staining and we identify organism and further treatment. The next second case is you can see a level in the anterior chamber. So this we would label as hypopyon corneal ulcer, which is an ophthalmic emergency. You just have to start one single drop of atropine, repeated antibiotic drops, again half an hourly, and send it to your ophthalmologist. The third case I want to discuss with you, because you can see that is a quiet eye. There is no redness, nothing. So probably it's a healed corneal ulcer, and the thing which you can see is just an opacity. Now this opacity being a very central and it hides the pupil and the visual acuity is lost, such patients can either go for a partial thickness keratoplasty or a penetrating keratoplasty. Next. So foreign body of eye, like I want the family practitioners and general practitioners can only deal with a conjunctival foreign body. See, you can see in first slide a black dot. That's a conjunctival foreign body. So what you do is, just ask your patients to turn head on that side wherever the foreign body is, and put either from a pint and an IV set a lot of water, or if you have eye drops having antibiotic drops, you can just pour in and try that this foreign body should go away from eye. If you cannot manage with that, if you have a sterilized Johnson bud, you can just ask the patient to look up and pick it up with the Johnson bud. This job is very easy, but it relieves a lot of itching, lot of foreign body like sensation, and sometimes localized redness in your patient's eye. After this, you must advise your patients antibiotic drops for at least 3 to 4 days. So this is one thing which you can really do. The next slide which you can see is, you cannot find in any foreign body over the cornea or in conjunctival sac. It is in the upper palpebral fissure. So unless and until somebody everts the eyelid, you cannot see that. So if at all you can evert the eye, this is also one very simple thing. You just take it away with Johnson buds, and the pain and everything, itching and everything of your patient's eye would get relieved. But never mind, if you don't find a foreign body, just don't juggle, because this particular foreign body, it's going to cause a harm to cornea. It may cause a scratch on cornea. So better if you don't find any foreign body, with a torchlight, with kind of retracting cul-de-sac, seeing all over the bulbar conjunctiva, send it to an ophthalmologist. Third thing, I'm showing you that black particular dot in cornea. I have seen many of my senior friends taking even such kind of foreign bodies with the help of a Johnson bud or a foreign body spurt. But I don't advise you to take out such foreign bodies, because if it is very near to pupil, or maybe if you have not actually used the sterilized swab, or you have not kind of taken proper precautions for sterilization, this may cause a secondary infection and corneal ulcer. So corneal foreign bodies are the one you ask your patients to see an ophthalmologist. Next. So another thing, somebody even told that patient just come to you, sir, आंख में बहुत दुखता है, બહુ દુખે છે આંખો, નજીકનું કામ કરીએ છે તો દુખે છે, for the far distance I have a pain, sometimes I have pain just at night, sometimes I have pain, I get up early in the morning, and all those of things. So remind you, unless and until you find out those cases which I have labeled as red eyes, which are treatable for you, pain in eyes is something that you have to just kind of differentiate. You may do that whether is it due to a hypermetropic refractive error. The plus glasses or hypermetropia, what we call a long-sightedness, may cause headache. So in that case, once again, you ask your patients to close eyes alternatively, and if he sees that I cannot see far distance thing, you must refer the patient to an ophthalmologist to rule out causes like even glaucoma and iridocyclitis before you label them as a patient of refractive error. Patients do have a sinusitis because of the frontal sinusitis or a maxillar sinusitis, lot of eye pain. So that also you can just ask by history that whether it increases on looking down, or do you have rhinitis, or are you a patient of frequent upper respiratory tract infection, and then you can rule out. So such pain in eyes, you can just have this particular very common differential diagnosis, and help your patients to either you treat them or you tell them to visit an eye doctor. Next. So headache is one very important thing. I think we all should know that, you just have to see what the age your patient is. If he or she is a child, you have to take it seriously, because it really causes a lot of harm for the studies and everything. And hypermetropia, again, in children is a very common cause. If the patient is a short-sighted, means he is a myopic, he won't have headache. So is a misnomer that you say that you have a headache and you have glasses. It's not like that. So one must take this seriously, because it really causes a lot of kind of underdevelopment for a child when he or she is having a hypermetropic refractive error. He really suffers in his daily routine. I already told you that one must rule out ENT causes by ruling out the history. And one important thing which we must not neglect is a papilloedema, that we have seen 5 to 10% cases having been diagnosed to have intracranial things by just looking at the picture of fundus, which is what you call papilloedema. Especially you find there is a slightest sign of intracranial pressure increase. So there is a meningeal irritation signs. There can be this, and even without that, we found that papilloedema has led us to a diagnosis of intracranial space occupying lesions and other things. Next. Somebody even commented on the lids. So I want you to just identify between stye and chalazion. See the first slide. Stye is a swelling of a lid margin, first and second. You can see it is exactly at lid margin. If I talk about the third and fourth slide where the lady is closing her lids, you can see, it is a little away from lid margin. See, this is the area where the meibomian glands are situated. So chalazion is a disorder of meibomian glands you find a little farther than the lid margin. And stye is at the lid margin, which is affection of a gland of Zeiss and mole. Now, both of these conditions are very different. One is acute inflammation, one is chronic inflammatory granuloma. At least I can tell you one thing, that eye drops, that is antibiotic drops, which you ask of a patient to put for stye, is just to prevent a secondary conjunctivitis. It's not going to help the patient. What you advise is, with a Johnson wort, you can just do hot fermentation for 3 to 5 times to initiate a inflammatory response. You can even give anti-inflammatory oral uh, drugs, and you can ask the patient to wait and watch. Never squeeze a abscess, that is the stye, because it is connected with emissary vein and it can even sometimes lead to cavernous sinus thrombosis. When if it is too severe, large pus more than 0.5 centimeter, you may give even a systemic antibiotic. So, but otherwise you don't need to do anything. You do this particular anti-inflammatory and antibiotic for about 3 days and nothing happens. This particular thing can be easily, one can pluck the eyelash. Probably I may not advise you to do is, but the treatment for the first line of surgical treatment is we pluck the eyelash so that the gland of Zeiss will, kind of, the pus will be released from that area. So for stye, antibiotic eye drops just for prophylaxis, hot fermentation, and systemic antibiotic and anti-inflammatory, especially if it is a chai. Okay, and chalazion is one that next is it requires surgical intervention. Next, so we just look very fast because I think the time is over. I'm very particular about that. So we summarize that, bacterial conjunctivitis, conjunctival foreign body, initiation of corneal ulcer treatment, emergency like chemical burns where you just can give a lot of wash with a pint, free flow with an IV set for quite some time, that's about half an hour. Even you can reassure your patient for an empirical line of treatment for leads, as I suggested you. You can rule out refractive errors, and you can even differentiate headaches. There is a lot many things you can help your patients. Next. So diabetic retinopathy, LASIK, trauma, vitamin A deficiency patients, again, we really can have a separate sessions because it requires one whole lecture. I need to tell you what all you can answer to the queries of your patients. Next. So I really thank you all very much for your kind attention. Happy practicing. And may I have any questions if you have?
Are we taking questions?
I can really help you out on a kind of patients you have seen in your clinical setup and you want me to help. How do you go ahead with that? I
Madam, your
thank
talk,
again Dr. Ashwin Bhai also to invite me and the whole team work of the Family Practitioner Association. It's wonderful time. Sometimes we meet maybe live. That will be very interesting because I am generally very interactive while I talk. I want really to help others in their practice ophthalmologically.
Madam, your talk was excellent, and there may be many questions in our delegates' mind, but we will give your number and they will contact you directly.
Sure.
As there is short of time, we have to take a last lecture also, and we are very short of time. Thank you, madam.
Thank you. Thank you so very much.